My name's Nick Hart. I'm a professor of respiratory and critical care medicine at Guy's and St Thomas's Hospital. And I'm going to talk to you today about home mechanical ventilation in stable and post-acute COPD, in particular thinking about who, when, how and why. And what we really want to understand is a non-pharmacological approach to treatable traits in severe COPD. Here is my conflict of interest and disclosures. This is the clinical physiology to clinical trials program that we set up almost a decade and a half ago. What we've driven through this process is an understanding of physiological mechanisms and how they impact on physiological outcomes, which then drive the clinical outcomes we have shown in clinical trials. The importance of understanding the physiological mechanisms allows us to match to health tech development, and so we can develop and ensure that our patients have the right technology delivered either in the hospital or in the home. And then once we have the tech development, we then have to do safety and efficacy testing, and then they'll take that through clinical effectiveness and cost effectiveness. When we think through the actual physiology over a number of years now, we've contributed to show that in COPD there's an increased neural-respiratory drive. And indeed, that impacts on patients with chronic stable respiratory failure and persistent post-acute respiratory failure. And we've been targeting carbon dioxide, we've been targeting the PaCO2, we've been targeting the transcutaneous CO2 in order to improve ventilation through the use of non-invasive ventilation. And then focus on the outcomes of health related quality of life, exacerbation frequency, which then allows us to understand and answer questions around clinical and cost effectiveness. So who, when, how and why to start home mechanical ventilation COPD, and more importantly, the right patient given the right treatment at the right time. I'll talk about PICO, target population, the intervention, the control and outcome, which is the way we design all our clinical trials. So patient selection, which patients would I select in terms of home mechanical ventilation in COPD? And it's first we're going to look at those patients with chronic stable COPD. And I'm going to draw on the Thomas Kernline study that was published in Lancet Respiratory in 2014. This was a multi-center randomized controlled trial of using non-invasive ventilation in patients with severe stable chronic obstructive pulmonary disease. They took patients with established respiratory failure, chronic respiratory failure on the background of severe COPD. These patients were very obstructed. They had an FEV1 around 30%. They were hypercapnic with a mean CO2 between 58 and 59 millimeters of mercury. But interestingly, and what needed to be understood from this study is they had preservation of their exercise capacity, and not all the patients, indeed 35% of the patients, were not receiving long-term oxygen therapy because they had preserved oxygen tensions in the arterial system of the blood. So when we look at these patients as well, it's not only saying that they had preserved exercise capacity and their oxygen requirement was unusual and with patients that we've seen in the acute setting, but they did have a low admission rate as well associated with this. So we've got to think about the patient populations we're treating in terms of those that are going to get the best outcome. So this study had severe COPD patients, severe hypercapnic COPD patients. They had preserved exercise capacity and a low annual admission rate, which one would hazard, and you don't have this in these data, but a low exacerbation rate. So patients were randomized to receiving standard COPD treatment and home NIV and LTOT, but only if indicated. And the patients were then targeted, or the carbon dioxide was targeted, and there was a targeted CO2 reduction. And it was a 20% reduction during a 7-day admission. 20%, or if the patient could get down to a PaCO2 less than 6.5 kilopascals. So with this targeted CO2 reduction, the comparator group was using LTOT if indicated with standard treatment. And the primary outcome was all-cause mortality at 12 months. And you see there was a significant difference in terms of all-cause mortality and a reduction in all-cause mortality in the treatment group, the home NIV group. And when you look at the Kaplan-Meier, you see that there was an absolute risk reduction, an ARR of 21%. And that's really important to understand because that gives us the numbers needed to treat. And so we'd need to treat 5 patients with NIV to prevent 1 death. So we see this as an important treatment in patients with severe stable COPD, with established hypercapnic respiratory failure, preserved exercise capacity, and low admission rate, which is a particular phenotype of COPD patients that we will see in our clinics. So when we think about how, when, and why to start home mechanical ventilation in COPD, going back to the question, the right patient given the right treatment at the right time, what we now need to think about is those post-exacerbation patients, those post-acute COPD patients, those patients that have come into our hospital with life-threatening exacerbations of COPD requiring acute non-invasive ventilation, and those patients that then have persistent hypercapnic respiratory failure. And the reason this group of patients were a group of focus and have been for our group is that although we have the acute NIV clinical evidence in order to reduce mortality of numbers needed to treat of 8, reduce the intubation rate of numbers needed to treat of 5, what we see in the patients with a post-acute, those with persistent hypercapnia after surviving a life-threatening exacerbation of COPD, have a poor outcome, with up to a 40% mortality. The important is to understand as well that when a patient comes in with hypercapnic acidotic respiratory failure, and if at the end of that admission or within a period after they have been discharged in the early recovery period, they have reverted to eucapnia, they have the same outcome as a patient who presents with a eucapnic exacerbation. So transient hypercapnia impacts on a different clinical outcome than persistent hypercapnia in the context of an acute hypercapnic exacerbation of COPD. So we need to focus on those patients with persistent hypercapnia using post-acute NIV. And this was the premise of the HOT HMV trial that Patrick Murphy published back in January 2017. And these patients who had persistent hypercapnia with a CO2 greater than 52 millimeters of mercury at 2 to 4 weeks after a life-threatening exacerbation requiring acute non-invasive ventilation. And the patients we recruited into this study were severe COPD patients. They'd had a life-threatening exacerbation, they had persistent hypercapnia, and they didn't have any other evidence for sleep disorder breathing or respiratory failure. So we excluded those patients with obstructive sleep apnea. Within the recruitment, what we actually focused on, and it's really important to highlight, is that we had a significant proportion of patients, as we had predicted, with a transient hypercapnia. And that transient hypercapnia meant that their arterial blood gas had reverted to eucapnia by the time we saw them at 2 to 4 weeks. And when we looked through the data, we found that 50% of suitable patients for assessment at 2 to 4 weeks did not have persisting hypercapnia. The patients were randomized to receiving standard COPD treatment, home NIV, and home oxygen therapy. And in fact, we followed a tailored titrated approach in terms of NIV setup, and we use a high pressure strategy. We were targeting a 0.5 kilopascal, 4 to 5 millimeter mercury fall in CO2 overnight during setup. The oxygen was started at the daytime rate, and we wanted saturations greater than 88% and a PO2 greater than 8 kilopascals. The patients in each arm received 1 litre per minute oxygen therapy as their LTOP prescription. Those receiving non-invasive ventilation had an IPAP of 24 centimetres of water, an EPAP of 4 centimetres of water, and a backup rate of 14 breaths per minute. As you saw in the Kernline study that was in stable chronic COPD, there was a 17% reduction in the CO2 over the period of the study. In the Kernline study, they targeted 20% during the first 7 days. With this study, we found that patients had a significant reduction in CO2 in the non-invasive ventilation group. It's important because CO2 is the target and the physiological biomarker in terms of outcome improvement in COPD. So the patients were randomized and the treatment group got home oxygen therapy. And the primary outcome was time to readmission or death. And as you saw, there was a significant increase in time to readmission or death in the treatment group, those that received hot HMV therapy, to those that received home oxygen therapy alone. And from the Kaplan-Meier plot, the important aspects to consider are the early separation of the blue and red line. The blue is the treatment group, the red is the home oxygen therapy group, and there was an increase in time to readmission by 90 days. And the likelihood of readmission or death actually was over 50%. This is the effect size that this treatment offers. When you look at the absolute risk reduction, and going back again to the Kernline study, which had a 21% absolute risk reduction, we saw a 17% risk reduction in the hot HMV trial. And what that means is we need to treat 6 patients with hot HMV therapy to prevent 1 readmission or death within the subsequent year. I'll draw your attention back to acute non-invasive ventilation in terms of mortality, and the numbers needed to treat is 8. And the numbers needed to treat for intubation rate is 6. So this is in line with the acute therapies that we give for exacerbations of COPD. We saw a reduction in the exacerbation rate by 1/3 in the treatment group. And again, you look at the Kaplan-Meier and you see the exacerbation rate actually separates early. So it's an early effect affecting the reduction in readmission. And when we look at 28-day readmission, again, you see this as an early effect. By 4 months, you can see that the lines are parallel, meaning that at 4 months, the effect has gone. And so what we need to make sure is during the early phase of adequately treated in terms of targeted CO2 reduction. And so with hot HMV, we saw a reduced 28-day readmission by 2/3. This is important in the context of the financial penalties or the reduced reimbursement in many healthcare systems in patients that are readmitted within 28 days. So who should we target for home NIV to improve outcome after an exacerbation, a hypercapnic acidotic exacerbation of COPD? We need to be seeing those patients at 2 to 4 weeks. And the CO2 greater than 52 millimeters of mercury with a PaO2 less than 55 millimeters of mercury, then we should be adding NIV to home oxygen therapy and providing hot HMV treatment. So why target CO2? Again, this is some post-hoc analysis, and it divides the patients up into the responders and non-responders. So those receiving non-invasive ventilation and those receiving home oxygen therapy. those patients that had a fall to below 7 kilopascals, 50 millimeters of mercury by 6 weeks had an improved outcome to those who had, in the treatment arm, those who had didn't have a fall in their CO2 at this stage. So what you see here as well is when I compare the home oxygen therapy group with the home oxygen therapy and home mechanical ventilation group, those in the home oxygen therapy group who had a fall in CO2, regardless of whether they received non-invasive ventilation or not, and this group didn't, they had similar outcomes. So that shows us the importance of CO2 targeting. And then when I look at those groups, the treatment group against the control group, if you are in the treatment group, and even though your CO2 doesn't go below 7, you have a significantly improved outcome over those in the control group who had a CO2 greater than 7. And this highlights the importance of targeting carbon dioxide in this patient group. So we know the who, we know the when, we know the how, and we know the why. And this was published in the ERS guidelines on long-term non-invasive ventilation for managing COPD. In the stable group, we want to take severe stable COPD who are hypercapnic with a preserved exercise capacity and low annual admission rate. Those patients are going to be the patients we are seeing in clinic. They need a targeted CO2 reduction. We know that we can do this in a much shorter period now than the 7 days that was in the Kernline study. And what we can tell the patients is we're going to reduce their 1-year all-cause mortality, but also from that study, improve their quality of life. When I think about the post-acute patients, these are again severe COPD with a life-threatening exacerbation, but they have persistent hypercapnia at 2 to 4 weeks. Again, we're targeting a CO2 reduction to increase the admission-free survival. And then we will show that this is a cost-effective treatment. Putting the pieces of the puzzle together, what we're doing is treating with home NIV. We're treating chronic or persistent hypercapnic respiratory failure to bring down the CO2. We're reducing the exacerbation frequency, enhancing health-related quality of life. The caveat to that is when you look at the Kernline study, this was a 12-month effect of improvement of quality of life. But in hot HMV, we saw that at 6 weeks, but that effect was not necessarily seen after that and out to 12 months. So with the improvement in mortality and also morbidity of the patients, we really ask the question, is hot HMV cost effective? And really, is hot HMV and COPD cost effective? Because we put a cost effective analysis into the study. This was work we published last year, and this is important for understanding not only the clinical effectiveness of a treatment, but the cost effectiveness of a treatment. And so we do patient level medical resource utilization, and the outcomes we use were quality adjusted life years and estimated based on the Euroqual 5D data. This is a table form of the cost by treatment. In red, you see that the ventilator costs, which are obviously more than the control group who didn't have a ventilator, show that there's an adverse device cost. But the green highlights where the total exacerbation costs and the total patient reported costs actually are favourable for the treatment group. So red is adverse to the treatment group, green is favourable to the treatment group. And then when we look at the adverse cost, is actually £518 overall. When you look at the total cost, the exacerbation costs and the reported costs. When we look at the health rated quality of life and the QALYs, that was favourable. And then the cost per QALY was favourable at £10,360 cost per QALY. NICE will fund up to £30,000 cost per QALY. And in fact, if you're in the last year of life, which many of these patients are, they'll fund up to £50,000 cost per QALY. So this is well within nice in terms of a cost-effective treatment. When we think about cost effectiveness, and we spend a small time thinking about the cost effectiveness planes, and for those not necessarily orientated into cost effectiveness planes, on the left is less effective, on the right is more effective, on the upper is more expensive, on the lower is less expensive. And where you would like to see all studies is actually in the top right hand corner. However, when we see with our novel technologies and novel treatments we have coming through, we often see them exactly where that red dot is, which is on the borderline of quadrant 4 and quadrant 1. And what this means is this is a slightly more expensive therapy, but more effective. And that is why we get a cost per QALY of £10,360. When we think about the COPD value pyramid, you see telehealth in terms of cost per QALY would not be funded, and that's why we haven't seen significant rollouts. But when you look at home non-invasive ventilation, it's at the 10,000 cost per QALY mark, which is not far off the inhaled treatments we're currently using today. When you put this together, and this was put together as meta-analysis and putting together the patients with a post-acute and a stable, pulling all the data together, not just the hot HMV data, it was shown that the post-exacerbation group is £11,000 cost per QALY, whereas stable COPD is £27,000 cost per QALY. So HMV or hot HMV is a cost-effective treatment, whereas HMV for chronic stable is less likely to be a cost-effective treatment. So we would say home NIV in COPD is clinically effective, as shown in both the post-exacerbation group and the stable COPD group, but also is cost effective, and in particular in the post-exacerbation patients with persistent hypercapnic respiratory failure. So exacerbation prevention in COPD, EPIC, is the program of work that we currently have running. We have EPIC HFT, which is exacerbation prevention in COPD, and we have a clinical trial currently running to investigate if home high flow therapy reduces 12-month admission-free survival following a severe exacerbation of COPD requiring hospitalization. That is with encapnic patients rather than our hypercapnic or our persistently hypercapnic patients. And EPIC OSA, which is to start this year, which is looking at the COPD OSA overlap syndrome and to investigate if positive pressure therapy reduces exacerbations in COPD OSA overlap. So there's a significant amount of work going on for exacerbation prevention in COPD to improve the outcome of our severe COPD patients. Big thanks to the group that I'm fortunate enough to work with, the Clinical Respiratory Physiology group, and for those partners that have supported our work over many years. Thanks for listening.